Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we bring you the conversations behind our clinical content. I'm the host of this program, Dr. Alyssa Watson, and today I am just thrilled to be joined by Dr. Andy Moorhead. Dr. Moorhead is a small animal parasitologist and associate professor at North Carolina State University. He recently authored a comprehensive review on Dirofilaria immitis, which we all know is the parasite responsible for heartworm disease in dogs and cats. So in this episode, we're going to discuss a little bit about the life cycle of D. immitis. We'll be talking about some of the latest treatment recommendations and some emerging challenges, including macrocytic lactone resistance, as well as something that is very topical to myself practicing in Las Vegas. And that is kind of the shifting geographical distribution and prevalence of heartworm disease in the US. So, Andy, thank you so much for joining us today. How are you doing?
I'm doing well. Thanks for having me on, Alyssa.
Yeah. Before we jump in to today's episode, I was hoping that you would just give a little bio, to our audience. Tell us a little bit about your veterinary journey.
So I, in vet school, initially had an interest in public health that would work its way into zoonotic parasites and eventually would lead me to heartworm. That is the short bio. Before I NC State grad and got the chance to come back here a few months ago, but before that, I was at the University of Georgia for 16 years, where I did heartworm research and some other parasite research and taught parasitology.
Yeah, so as I kind of alluded to, Las Vegas, Nevada isn't really like a heartworm hotbed, at least traditionally hasn't been. So this is a disease that I have only treated, I think, once or twice over my 20-year career because I've always practiced in Nevada. So I've got lots of questions. I'd like to start just a little bit, kind of a refresher, if you will, on the heartworm life cycle. We know it's really complex. There's a definitive host, intermediate host, and I'm sure as someone who is so dedicated to studying heartworm, you could talk about this for, hours, but maybe just kind of some of the key developmental stages of Dirofilaria immitis for us.
Yes, I'd be more than happy to, and I will try to keep it brief. I will always say one thing before I launch into life cycle. When clinicians are talking to clients about this, can't emphasize enough using some visual representation of the life cycle. As I go through it, I can explain it quickly, but I think for students, for anyone, essentially realizing that clinicians are educating clients every day, that having a simplified picture of the life cycle helps. And the main part of this is, of course, the mosquito. Without the mosquito, heartworm could not be spread. And so that's extremely important. Remember, extremely important to emphasize to the client that we are dealing with this disease where if they are exposed to these flying syringes, they can get heartworm. So if we start in the adult animal, of course, we have these long worms up to 6 to 12 inches in the pulmonary artery. And they can sometimes get in the heart, but their normal resting place, pulmonary artery, of course, may produce microfilaria, which are extremely tiny and an important diagnostic stage, which I'm guessing we'll get to later in this discussion. Mosquitoes pick up the microfilaria, and they undergo a requisite development in the mosquito, undergo a couple molts, and there's a variety of times out there that are listed, but let's just generally say anywhere from 10 to 16 days it takes for them to develop to the third stage infective larvae. Now, with that being said, of course, depends on humidity and temperature, and there's been a lot of studies and math around that I won't go into today. But it takes that time, and once that third stage larva has developed, it undergoes complicated migration in the mosquito, which I won't go to, but it works its way back to the mouth parts. And the mouth parts of the mosquitoes, there's this syringe stylet, but there's also this fleshy part, labia labellum. And these L3s end up in there. And when the mosquito actually bites its next host, whatever that may be, um, those mouth parts actually will bend, and the third stage larva, L3s, which I'll refer to them now in moving forward, will actually bust out and are deposited on the surface of the animal. And so that when that stylet actually pulls out, those L3s swim through the hole. And this may seem like a point of semantics, but the actual thing is they are not injected. They are deposited and then swim through. But I will tell you, having observed this happens very, very quickly. Now, when the L3s are in the definitive host, long, complicated migration that molt to the L4 or four stage larva happens pretty quickly around day 3 or 4. Then it undergoes a long, long migration through the subcutaneous tissue, sometimes the musculature, and eventually, as early as day 67, will end up in the pulmonary artery. And at that point, it's probably going to be roughly around an inch. And once they're there, they will grow to that full length. And from what we know, based on the studies that were done, realizing the last definitive study on the heartworm life cycle was done in 1982. So that's all we've got to this point. But by day 120, 4 months after infection, those worms will be in the pulmonary artery, and as will become important later in the discussion, that is well before we can detect them using tests.
Yeah, I think you covered a couple of key things there, and that was, one, the fact that, those larvae are not injected into the bloodstream. You think of, the mosquito biting and taking a blood meal and putting those larvae straight into the bloodstream, but that's not what happens. And the other thing, you said was the length of time this all takes, and the larval migration and maturation, that really comes into play when we're talking about testing. We have these standard heartworm antigen tests, and those rely on detecting adult female worms. So there's that time. What are the latest recommendations from the American Heartworm Society regarding testing? Because I think that those have changed recently.
So in this and for this answering this question, I'm just going to talk about dogs. If you want to dive further into cats, let me know. So with dogs, an important fact I forgot to mention is that time that it takes from the larva entering the host to becoming mature and producing microfilaria, that prepatent time, which term we use is 6 months. And so that 6 month window, which you always hear anytime you're talking to anyone's talking about heartworm, that's where it comes from. And it's important to remember that most of the patient side tests and send off tests we use are testing for that female uterine antigen, I should say female adult uterine antigen, which can sometimes be detected a little, earlier than 6 months, but just practically, I'll try to say 6 months. So we definitely recommend testing for that, which using whichever patient side or send off platform you want. The other thing that we do recommend is looking for microfilaria in the blood. And this recommendation we changed about 10 years ago, because before that it had just been antigen, due to some newer data that had come out. Now there's going to be a subset of your listeners who will be like, wait, I remember when we just used to test for microfilaria and that was good enough. Then antigen was here and now you're bringing microfilaria back. Why is that? So what we're recommending for both actually for all animals, and there's every time I talk about this, I get a little pushback, is both testing for antigen and microfilariae. And the reason for that is there's some newer data to suggest that antigen, if you think about it coming from the worm, it's in the bloodstream, and the host may mount a response to that, which would be antibodies. And so, if the antibody level is high enough where it essentially binds up the antigen and you pull that blood, it essentially will be masked from the test. And this is known as immune complexing. And so, in the cases where this happens, which we're still figuring out exactly all the cases that happen. That testing for microfilariae provides a backup. So if you have, if you have an animal and you're testing it, you do both, and it comes up antigen negative, or more appropriately, no antigen detected, but microfilariae positive, then we need to send it off for further testing. And this is where and a lot of your listeners will have seen this, where this idea of heat treatment comes in. And when we're talking about heat treatment, what we're talking about is heating the serum, actually boiling it, which causes the antibodies to denature, and that antigen is now available for the test. Now, all this, what I'm saying, is in the revised 2024 American Heartworm Society guidelines, which we've tried to put everything in there, for including the kitchen sink. So if you have questions about anything that I've said, deeper dive on that, that's where it'll be. Now, and when we when we recommend heat treatment, there are a few different scenarios. We don't recommend it on all animals. We recommend it on that animal that is microfilariae positive, no antigen detected. Recommend it on that animal that, especially for those of us, because I'm based in the Southeast, I mean, seeing quite a bit of heartworm, you're like, there's no way this animal is negative, and maybe we've got microfilariae, maybe we don't, so we have symptomatic recommending that. And then an animal in a highly endemic area that you think should be positive. I'm thinking of those rescue dogs that are out there that have been on the streets. We adopted one that had been on the streets of Savannah a few years ago. Definitely ran a heat treatment, or ran all the tests on her, ran heat treatment, and I still don't know how she wasn't positive. But those are the situations where they use that, and where that might come in to your area with Las Vegas is, there's increased animal movement with significant weather events. And just, as those animals come into to your area, and I'm not saying anything negative about that, I think it's very important. Just realize that you could encounter these situations as well. And this is where you may want to do those testing modalities.
Absolutely. Just kind of expanding on that a little bit. So these antigen antibody complexes could potentially yield a false negative result. Certainly, I've heard of all male worm infections causing a false negative. Anything else that we should be aware of, where we should be suspicious of our results?
With the all male, I will say that that's definitely something to think about. But in dogs, that's primarily going to be lower number infections, because if you think you have a 50-50 chance of having a male or female, the probability of having a 10 to 20 worm all male infection is going to happen. So all males, definitely immune complexing. But then this idea of testing during the pre-patent period, which I'm really glad you brought this up, because I've already talked to you about, it takes 6 months basically for us to detect this. But when an animal comes into your clinic, you are literally taking a snapshot in time. You do not know where we are in that infection cycle, as it were. So if you test and that animal's positive, and by positive, I mean infected. But if you tested 2 or 3 months, that will not come up on that test. And so that is definitely another time where you could not detect antigen. And that's why, especially when we do explain this in the guidelines, if you have an animal that, you test and initially no antigen detected, but there's some question about compliance, or it's never been on prevention or anything, testing 6 months later, you should hopefully catch that as a positive. Now, I'd say I've simplified a somewhat complicated conversation there, but basically, take home is you test and it's negative, you're like, okay, maybe I need to come back in 6 months later. Now, what I'm not talking about those annual visits, that annual testing. This is different. So.
Right. And that leads into kind of our next topic of conversation, too, which is about preventive. Because, the preventives that we have available to us, when we're giving them depends, it's the life cycle of this parasite and how those medications work is a little bit different than we think of as some other anti-infectives. So, people refer to heartworm preventives as heartworm medications, but that can lead to misunderstanding with clients and even, within our staff. So, could you talk a little bit about macrocytic lactones, since those are kind of the cornerstone of our prophylactic treatment, and why they're considered prophylactic and not curative?
Yes, it's actually I love talking about this topic. With macrocyclic lactones, and I need to remind people just what a powerful class they've been in as far as anthelmintics in both the human and animal realm. I'll remind people, Bill Campbell won a Nobel Prize for ivermectin um, some years ago. So these are extremely important drugs. So we say preventive, and that is really, we use that term colloquially, but you think that we're actually preventing infection. And the question you're asking is an important one, in that we essentially are letting the animals get infected every month, which may sound harsh. But when we are giving it, and ideally every 30 days, depending on the compound. You give it, and any larvae that were there present before, they'd be primarily, anywhere from the L3s, all the way up to mid L4s, we are killing them with those preventive. Long acting ones, it's going to be roughly the same idea. The worm has to get in, and at some point, the drug is acting on it. And what we're actually preventing is those worms reaching the pulmonary artery and causing disease. And so it's somewhat the old analogy you'll hear: if a forest falls in the tree, or the tree falls in the forest,
Mm-hmm.
uh, that when that happens and no one's there to hear it, it's the same thing with preventive. Forests don't fall in a tree. But anyway, so that's the basic idea of these. And around that, just practically, what I recommend to people is be adherent in that time when you give it, regardless of whether you're giving a monthly or longer acting, 6 or 12 month. But one thing to emphasize to clients is the letter of the law is every 30 days, but I think practically just the same day of the month. Because I've had people come up to me and say, well, not every month has 30 days. And I'm like, yes, I realize this, same day. Because if I say to you every month, what could you say, Alyssa?
Every 28 days, every 30 days.
days, or you could
Yep.
give it the first to 1 month the end. So just that
Yep. Yep.
consistent
And
day.
the 31st of the next.
Yeah,
Actually, you just reminded me that it's the second of the month and I
it
forgot to give the dogs
is.
their preventive
Oh,
yesterday.
oh, yeah, yes, yeah, I definitely am like first of the month. So, and I always
So
think
I
that.
will be doing that right after our conversation
Thank
today.
you, thank you.
I think, well, so here's where this comes in for me. And I know that this is not recommended. It's recommended that every dog everywhere get prevention every month, or as you said, whatever prevention they're labeled on, if they are on one of those longer acting, maybe injectables or something like that. But so I will say that practicing where I do, I have a lot of clients that travel, and so it's something we ask, especially, in summertime when kids are out of school and, people are traditionally traveling out of here to get away from the heat. Are you going somewhere where your animal might be more at risk of heartworm disease than it is here in Las Vegas? And I have a lot of people that want to give their flea and tick medication and their which for flea and tick medication, it's great. You give it and then you go on your trip and your animal is protected. But they want to give their heartworm treatment or not treatment, their heartworm prevention, and then go on the trip. And I have to explain to them that's not how it works. Really what you need to be doing is giving it when you get back because the animal was exposed, while you're there, and then we need to kill that larva. And so having that conversation with clients and even with my staff, to get everybody on the same page on how these are working, I think is something that's really important because I've seen cases where owner thought they were protecting their animal and they weren't.
And and I think one thing that, and hopefully I'm answering your question on this, that idea of consistency,
Mm-hmm.
um, adherent administration, and one analogy that I use, which not everyone agrees with, but I truly view prevention like a seatbelt. You you want to have given it to make sure that the animal is safe, and I do acknowledge your point that way of explaining it, that we're not preventing forward, we're actually
Mm-hmm.
killing killing backwards. Now certainly if there's um, you know certain molecules that if they're on board will be around for for a while, but still the idea is the worm still has to get in there before they work.
Right. Exactly. Can we talk a little bit about the products? This is something certainly that, I know I'm not probably up to date on all of the latest products because we do see so little heartworm here. There's lots and lots of them out there. How do you approach selecting the most appropriate preventive for a given patient?
So, of course, every company wants you to say that theirs is the best. Um, but that's actually good news because that means we have a huge amount of good products out there. And the same, I'll tell you the same thing that I've been telling students and CE for years. The right preventive is the one that covers the parasites you're worried about, realizing that a lot of these preventives cover more than one parasite, that the client or you can adherently give. That gets our monthlies as well, as our injectables, and also fits the culture of your practice. I think you and I both well know and have talked to enough veterinarians that um, veterinarians will have company loyalties more fervent than any sports team out there. And so, because of that, I don't really make branded recommendations because what I ideally want is I'd like to see clients on something consistently. Now, with that being said, the parasite coverage and what the client may want to give And that goes to, we have to think about, does the animal like the taste? We can't discount you know, if something causes an animal to vomit, or if the owner doesn't like the smell, or, if it's, on the animal that they don't like the feel. Those things may be like, well, we shouldn't think about those, but we absolutely have to. And so ultimately, the right preventive is the one you can get, make sure is getting in the animal consistently. And that has been my consistent message for years.
And that's a really great answer, because if we can't get it in the patient, then it has no chance of working. So, I was a little bit surprised in reading your article that we don't really completely understand the exact mechanism of action of macrocytic lactones. But we do have kind of an idea of how we think they work. Could you explain that to the audience?
Yes, and this it's kind of funny you asked me that, because people are doing research on mechanisms of anthelmintics, and obviously we're a fairly small community, so them, they would probably laugh at my answer. Um, Definitely, we wonder whether they have some direct effects. One, and I'll say newer hypothesis, has been around for a while, is that it's not that there may be some direct action of the drug. And I'm going to say this a little bit of hand waving, because these are still active areas of research. But the idea that these worms secrete a lot of secretory products. And within these, there's going to be proteins. I they could be in these extracellular vesicles that, can contain certain small RNAs known as microRNAs, which may be interacting with a host. But that's the basic way of saying, the idea is, imagine these things are being excreted, and are either taking out the immune system so that it can't recognize the worm, or cloaking the worm, like an old Klingon ship, if anyone watched Star Trek, that where the worm couldn't be seen. But the whole idea is that the worm's doing something that is protecting it from the immune system. You shut down that secretion, or whatever that may be, the immune system can now see the worm and take the worm out. I've literally summarized hours of presentations that I've seen on this, and way oversimplified this. I realize this is a shorter podcast, but for people who are interested in that, they do need to dive deeper. But that is at least one of the very strong hypotheses how we think these drugs are working with respect to heartworm.
Right, exactly. And then, how concerned should we be about macrocytic lactone resistance, specifically like in the United States?
So, resistance, you could bring other people that work on heartworm, you'd get a variety of opinions on this subject. I want you to know. What we do know is that macrocyclic, let me back up. Worms, are going to have anthelmintic resistance. It's a natural consequence of use. Where we've most seen this, any large animal person who happens to be listening on this, you said you did mixed animal, you've dealt with
Yep.
this.
Yep.
We are less aware of this in small animals, but one thing that has been documented is that there is phenotypic resistance to macrocyclic lactones for heartworm. That is, in the face of continued prevention, adult heartworms have developed. Now, with that being said, that is only a subset. Initially, when these this really started bubbling up was back in 2005. But these cases were primarily in the Mississippi Delta / Mississippi River Valley. Once saw a big debate on what it was called. That's where it primarily was. There's now some evidence to say that may be broader, but really we are still getting our arms around that. I think some more data will be coming out about that. But the thing I have to emphasize is that I still give my animal macrocyclic lactone, and I hope everyone else does. Because if you have, well, I've heard there's resistance, so I'm not going to give it. You've just let in the way more susceptible worms that are out there. So I don't want anyone to take away that, oh, there's resistance. What, do I even need to worry about doing this? Yes, you need to be worrying about it. Consistent prevention is still our best shot at keeping this down. So, heartworm down. So, should you be aware of it? Yes. If you have a client where they, definitely have been giving consistent prevention and this comes up, first thing you're going to do is call the company. Definitely call the company. And there's, they have certain algorithms you'll work through. But just because a client that has been somewhat on prevention comes up, you really need to dig into that compliance angle. So that's my way. In summary, it's out there. You need to be aware of it. We don't completely know how much is out there, but definitely still keep giving prevention.
Looking for that special clinician or veterinary nurse to fill your job opening? Job seekers from all areas of veterinary medicine can meet their ideal match on the Clinician's Brief Career Center. It's the best place to post your unique job opening and know it will be seen by that special someone. Get started at cliniciansbrief.com/career-center. We're going to turn our attention to treatment if we can. So the current American Heartworm Society treatment protocol includes melarsomine, but also prednisone, doxycycline, a macrocytic lactone, a mosquito repellent, and an isoxazolone. So I will tell you, early in my career, I was taught when, you test for heartworm before you start a macrocytic lactone, because there was this concern that if you gave a macrocytic lactone to an animal that was heartworm positive, that you would get this massive microfilaria die-off, which could lead to anaphylaxis. And this was something that you never wanted to do. And so when that recommendation kind of changed and the macrocytic lactone, they started recommending giving that, before even treating for heartworm disease. What have we learned that's led to that change in protocol?
So, and you and I obviously talked about when we were trained, and it's somewhat around similar times. And the biggest thing about heartworm preventive, giving it to a positive animal, diethylcarbamazine or the daily, Filaribits, or for the
I remember Filaribits.
You remember, yeah, and definitely the more seasoned people on this podcast, Dirocide, which was this little apparently horrible tasting liquid, that was a daily preventive. And if you gave it to a positive animal, you definitely risked the animal dying. Now, when macrocyclic lactones came about, and there's obviously, ivermectin, milbomycin, moxidectin, which is in quite a few different formulations, and of the newer products coming out. Definitely, all the newer products have had moxidectin and selamectin, and then there's a newer cat product out that has a prinomectin. So those are the five that we talk about. Depending on the dose and the what's given, there can be rapid death of microfilaria. But if you notice in this discussion, um, would take longer than we have. But to simplify it, if you notice at the beginning of the Heartworm Society treatment guidelines, what you'll see is check for microfilaria, see if they're present, and if so, before giving that macrocyclic lactone, give diphenhydramine or some antihistamine or steroids, and it mitigates that. Now, there are a lot of opinions about this. Historically, ivermectin was the one that was given at the beginning because guess what was the first to market? What was the first that was discovered? It was ivermectin, and there's a lot of research surrounding that. But there are certainly, others out there that you can give the topical moxidectin products, of which there are a few, are actually labeled, FDA labeled as microfilaricidal, which for the FDA should be, safe to give. So with that being said, you can give it, but I recommend pre-treatment for diphenhydramine and steroids. But I will say from years of experience, what determines this, especially for younger veterinarians, is normally what your practice has done for years. They normally have a protocol for this, and it's normally worked for them.
Okay. Doxycycline plays a really key role in heartworm treatment because it targets this Wolbachia species. This is another thing that I kind of learned about, I think after I had been in school. How does eliminating Wolbachia reduce inflammation and improve our safety when we go ahead and then move on to our melarsomine therapy?
So, Doxy definitely, I'm trying to remember. This would have really been in the last 20 years or so, but it's this bacterial endosymbiont that's related to rickettsia. It is not only inside the worm, but it's inside their cells and the worm cells. But it and Dirofilaria and Wolbachia are in the most codependent, needy relationship ever. They both need each other to survive, is the simplest way to put it. But I said Wolbachia is related to rickettsia. The surface proteins are extremely immunogenic. So doxycycline, ideally, is bacteriostatic. Wolbachia is going to be protecting itself from being eliminated by the worm, and there's a lot of cell biology that goes into that, which is still heavily being researched. But basically, doxycycline, if those Wolbachia can't protect themselves anymore, worm cells are eventually going to break down the Wolbachia and get rid of those surface proteins. And when we use melarsomine, the worm does not immediately die. It does not explode like the Death Star. It crumples up and goes downstream, and the immune system takes care of it. So when that happens, we don't want a bunch of immunogenic pieces of bacteria or bacteria in there. And that's why we give doxycycline. And then why, if you look at heartworm treatment, after we give doxycycline, we ideally wait a month before starting melarsomine because it allows for more elimination of that Wolbachia.
And then another thing I think certainly can be overlooked is kind of mosquito control. So the American Heartworm Society definitely recommends mosquito control all throughout treatment. What mosquito repellents, are available?
So, what are repellents are available? There are quite a few that are out there that are labeled from a variety of companies. Normally, it's something that's going to be permethrin based. But what I do need to emphasize is that mosquito repellency is never a replacement for prevention. And this sometimes comes up as a point of confusion. Do not think that if you just put a repellent, you are protecting your pet. Now, if I may talk about repellency and the isoxazolines
Mm-hmm.
together, realizing repellency ideally would keep mosquitoes away. Isoxazolines aren't going to prevent a mosquito from biting, but what we have discovered is that isoxazolines, wow, they work on fleas and ticks and all these other ectos. Wow, they kill mosquitoes. It's not rocket science. I mean, it's logical that this would occur, and it seems based on some more recent research, I would say it's class wide effect. But what we're doing with repellency and or isoxazolines, or normally make one choice or the other, is we're actually preventing spread of heartworm, because so often people think of heartworm as this individual animal disease. One message that I try to spread is that it is a canine public health threat. And while we're thinking definitely about we want to get that animal clear, you know, these animals can have microfilaria. We've talked about that. If a mosquito either can't get to the host or bites and dies before transmission can occur, we're protecting those animals around
Right.
it.
Yeah. Yeah. So we're protecting the animals, the dog next door.
And there's been, there definitely been studies done about that one animal and how it can spread around. There was a particularly compelling one that came out of Arkansas probably about a decade ago about how this one animal, and it resulted in the spread in other animals being positive.
So right now, the American Heartworm Society is recommending the 3-dose melarsomine protocol, and that's really the standard. Why? Why? What's the basis behind that recommendation? Why do they want that versus something like the 2-dose regimen, or even you've heard talk, and I know it's not recommended, but this slow kill method. And so I'd really like to give a little time to why that's not recommended.
Um, so, what ultimately people need to remember is that these worms, and I alluded to the length before, 6 to 12 inches, are in the pulmonary arteries getting pushed back and forth, thousands to, I can't do the math on that, but a lots of times. And every time that worm's going back and forth, because this goes to pathology, it's causing damage. And there's going to be some initial damage, and then eventually there, and I use this term very loosely, maybe some healing, but that's fibrosis. Vessels are more non-compliant, and this is where we see a lot of that result in pathology, more severe cases, from pulmonary hypertension to hepatomegaly to ascites. So, with that being said, we ultimately want to get the worms out of there, as many worms as possible out of there as quick as possible. And that's what the 3-dose melarsomine does. Now, I realize that there's a month gap between that first dose and those second and third doses, which are 24 hours apart. But with that being said, you use that regimen, use the AHS regimen, we're going to get about 99% of the worms out. With the 2-dose, which is still highly effective, you're going to get roughly around 90. And depending on which slow kill modality you do, you can get varying degrees of efficacy. But with both the 2-dose and the slow kill, when you calculate efficacy, it's a total number of worms eliminated. But what you need to also look at in all the studies are how many dogs still had worms. And say with one 2-dose study, and these studies are typically, don't have a huge number of animals, there was still one worm left in 3 of the 6 dogs. In one's a slow kill study that comes to mind, there were still 3 worms left in 8 dogs. So those worms are still there. So that 3 dose gives us our best shot to get the worms out of there once again, most quickly. Realizing that also with melarsomine, when we give it, we we know the window that those worms are going to die. It's pretty defined, 7 to 10 days or so, which feeds into exercise restriction or activity restriction, which is extremely important. And with slow kill modalities, we don't exactly know when the death of those worms is occurring.
And yep, that was exactly my next question. Just like you said, exercise restriction is really emphasized all throughout the treatment. I had a question about how long they should be restricted and what are the primary risks, if you have a dog that exercises while they're undergoing treatment, and how do we, talk to clients about that, and stress the importance of it, but also not scare them.
It, So I think that as we portray this to clients, I always say this is the most personal part for the client of treatment, because this is, I mean, granted, they brought the animal in, they've, are getting the medications and doing all that, but this we really, really rely on the owner. And with that, we need to gauge with the owner how easy it would be to activity restrict. And by activity restrict, the strict definition is cage rest except for leash walk. And I've asked students for years, I'm like, if you had to do this with your own dog, how would that work? There's always a lot of, well, I don't know how that would work with my own animal. And I think of my own personal dog now, if she was heartworm positive, she would eat a crate in half. I don't know exactly what I would do. So, as owner, on a scale of 1 to 10, how reasonable is this? And then I think there needs to be some negotiation, and I don't use that in a bad word, but maybe a small room will work better. Maybe, certainly if the dog's outside a lot of time, rather than letting it run around the whole yard, can we get it to a smaller pen? So while crate rest is the strict definition, that's not always going to work. So we need to get those animals in as small an area as they can be without being overexcited. And leash walk, that's non-negotiable. You need to do that. You need to emphasize, define what it means. You're not throwing ball with the animal. If you used to run with your dog, you're not doing that during this time. Because when those worms die, they're going to collapse and go downstream. So imagine you have this massive thing that is now lodged in a vessel and causing inflammation. And that's why it's so important.
One of the really severe manifestations of heartworm disease, the most severe really, is this cavil syndrome. And what clinical signs should alert veterinarians that this is a real emergency that needs surgical intervention? And then what are some of the key considerations for performing that procedure?
So I have to say, first of all, I am not a surgeon. So I will not necessarily be talking about procedure. These animals, there's going to be very little question that they are cable. They can literally be passing out. They can extremely dyspneic. Um, they may not even really be able to move that much. One hallmark ClinPath sign is hemoglobinuria. And the reason for that is you have cavil syndrome is a huge number of worms, normally relative to the size of the dog. Obviously, with the Chihuahua, it's going to less worms could still cause it. But just let's view that those vessels are packed. It's backed up into the heart, maybe even into the jugular, and that RBCs are just being sheared, and that's why we see the hemoglobinuria. These animals are just a severe presentation. There's no other way to say it. I mean, extreme respiratory distress and almost down and out. And at that point, surgical intervention is what you have to do. What I tell people, ideally, you may need to, get it to a referral institution, but that may not be a possibility for a variety of reasons. So you may need to do the surgery yourself, which involves a jugular cut down. And there are a variety of ways to retrieve worms. And this is where people either chuckle or roll their eyes. There are an amazing number of YouTube videos on how to do cable surgery. So, and I've known people, who've done this, and they became sort of the local expert in their area, and they were the ones doing it. I mean, certainly alligator forceps have been used. There's some specific instruments. One way that I see a lot of is a red rubber catheter with suture tied on the end of it. You literally go down, twirl it out, it comes around out like spaghetti. There's obvious risks. You don't want to break a worm. Realize they're bags of antigen. We don't want to cause anaphylaxis. And as far as anesthesia for managing these, I defer to the anesthesiologists. I've heard definitely everything from these animals are so down and out, you don't need to anesthetize them, to you definitely do. So yes, I know. That's why I'm saying talk to a surgeon or anesthesiologist, not uh, for me, not to me about that. But the one point I have to emphasize is people will say, I'm scared to do this surgery. The animal may die. But what I can tell you, if you don't do the surgery, the animal will die.
Exactly. Yep. Yeah, and I would have to say I'm a pretty adventurous surgeon, and I have used YouTube to learn a lot of different surgeries. And so, although I'm very, very lucky that we do have a wonderful tertiary facility, here in town, and so that is when I would probably be booting. But
And I know that in certainly in university setting, it's normally the cardiologists,
mhm.
using fluoroscopy, and but um, in some more rural areas where you may not be able to get there in time, you may be doing it yourself.
Yep. After treatment, what is the timeline for retesting these dogs? And should we be retesting for both microfilaria and antigen?
So the recommendations. Let's address microfilaria first. Um, you're testing about a month after that last melarsomine, and um, not going into a lot of the details, but due to prevention and doxycycline, most of those microfilaria should be gone by that point. If they're still there, I would say definitely consult a parasitologist, because you could be uh, that's where you could be potentially dealing with a resistant strain. I use that in quotation marks. I'm not saying that everything out there is resistant, but if it's still there, the adult worms are most likely, going to be gone, but we still have microflare. The more important benchmark, though, probably is that the antigen test. And what we now recommend is 9 months after the last melarsomine treatment. And certainly this is a goalpost that has moved over the years. It was earlier and now has become later. And a lot of the reason is that is we're still getting a handle on how much that residual antigen can be circulating around. And if it was at 6 months, I would say, well, I don't want to necessarily retreat this animal with melarsomine yet. Let's give it 3 more months and make sure. And this 9 month, and realizing this, the AHS, American Heartworm Society, came up with these guidelines, and it was consensus that 9 months was that point where we felt if the animal is still positive, there's still some worms probably there. And that this is where I need to say with melarsomine, it is 99%. It is a really, really good drug, but a worm could slip through. That doesn't mean that there's resistance to melarsomine. What it means is just efficacy. Or melarsomine, there's some mistake that can be made during administration, and that we may not get that efficacy of kill. But bottom line is, if it's 9 months, I would definitely re-administer doxycycline, and then we generally recommend 2 doses of melarsomine at this point.
At that point, okay. And then we've kind of, just to wrap up the episode, we've kind of alluded throughout today's discussion about changing factors, pet relocation, climate change, mosquito adaptation, and these are all reasons that heartworm disease prevalence, can be shifting in the U.S. Particularly mosquitoes. I'd kind of like to wrap up with just a question. What do we know about the changing populations of mosquitoes within the U.S., and how should we be discussing that risk with pet owners?
So first of all, and full disclosure, as far as mosquito populations, the dynamics, I'm not an expert in any means. But we do discover new, mosquitoes that maybe we hadn't thought would carry heartworm can. We're constantly finding out about expanding distributions. There have been some invasive, at least one invasive species that I can think of. And so the bottom line is mosquitoes are getting more and more places that we didn't necessarily think of. Now, are they everywhere? Probably not, but they do seem to be going more places. I realize that is an extremely simplistic answer, but that's something that I feel confident saying. And that if a new research was to come out, we found mosquito X where we hadn't previously found it, and then discovered that, or mosquito Y that we didn't think could carry heartworm, but it can, none of that would surprise me at this point, because we do have so many changing environmental factors.
Yeah. Well, that was all of my clinical questions, and I thank you so much for joining us. But before I let you go, I do have just a couple other kind of fun questions. We like to wrap our episodes up with something we call rapid fire. It's just a game of would you rather questions. Would you like to play with me?
Yeah, sure. I may choose not to answer depending on what it is.
Okay, well, you can choose not to answer. We'll give it a try. We'll see how you like it. Ready for your first question?
Yes.
All right. Would you rather find out the kitten you were just snuggling has ringworm, or that the puppy that just licked your face has scabies?
Ringworm or scabies? Probably the puppy with scabies.
You take the scabies?
I'll take scabies.
Would you rather have a parasite named after you, or would you rather discover a new class of antiparasitic drugs?
Definitely the second.
The second.
And I hope any parasitologist who doesn't answer that way is not dedicated to the profession, because we desperately need some new drugs in different classes. That's easy.
That's easy. All right. Would you rather your microscope had a broken condenser, or your centrifuge was always unbalanced?
Broken. Always have broken condenser. Well, I don't know. That'd be really annoying with the microscope. Centrifuge, just stick it in a different room, shut the door, hope nothing bad happens, and ignore the noise.
Ignore it.
It'll still run.
Just go pick the pieces out.
Really, it'll be really loud. So, I'm sure there's some people that disagree with me on that one. So,
All right, last question.
yes.
Since pinworms are species specific, do you think that a centaur would get human pinworms or equine pinworms?
So what I would say is probably since the back end is on a horse, I would say Oxyurus equi. But it would really depend, is the intestinal tract more towards a human or a horse, which I've never heard anyone discuss with the centaur.
Yeah, I'm not sure. I think that's the real question too.
Just it's an intriguing thing. I don't think anyone will be funding centaur research anytime soon.
Probably not. Probably not. Well, again, thank you so much for coming on, for sharing your expertise. And to all of our listeners, we appreciate you turning in, and we hope to catch you next time on Clinicians Brief the Podcast. Thank you for listening to Clinicians Brief the Podcast. If you enjoyed today's episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcasts on our website at cliniciansbrief.com/podcasts. Or drop us a line at podcasts@instinct.vet. Clinicians Brief the Podcast is an Instinct Science production, produced by Alexis Ussery and hosted by Alyssa Watson.